ARF, or acute respiratory failure. This is a state. This is a condition. This is never a primary diagnosis. So when you see acute respiratory failure as a diagnosis, it's missing something. Secondary to what? Okay, what's causing the respiratory failure? So most cases are sepsis, actually. So sepsis, it could be from pneumonia, but they're in a state of respiratory failure. It could be COPD. It could be um, pancreatitis. Okay, it could be from opioid overdose. Could be from Guillain-Barré syndrome. Could be from ALS. Okay, a whole list of causes. All right, because the diagnosis of respiratory failure, this state or this condition, is made based on your ABG. When we draw ABG on a patient and it shows the following: a PaO2 less than 60, normal is 80 to 100. A PaCO2 of greater than 50, normal is 35 to 45. And arterial pH is less than 7.35, normal is 735 to 745. If you have all three, then you are in respiratory failure. The causes are a long list. There are pulmonary and non-pulmonary causes of respiratory failure. Again, what is respiratory failure? It's a state, it's a condition. When do you meet this condition? When your ABG shows what? Come on, children. PaO2 less than 60, PaCO2 over 50.
pH less than 7.3.
Okay, all right. And then some authors will say there's another condition wherein the oxygen saturation is less than 90.
Oh.
Right? That's also a condition to meet respiratory failure. Good thing about respiratory failure is it responds to oxygen, meaning the only treatment for respiratory failure is oxygen therapy. Whether you use cannula, a mask, BiPAP, a non-rebreather, or you intubate the patient, they respond to the oxygen therapy, meaning they improve. Okay, so that is just symptomatic though, because what's causing the respiratory failure? Yeah, so there are underlying conditions that led to it. So until those underlying conditions resolve, will respiratory failure ever resolve? No. So until then, until you resolve the opioid overdose, the pancreatitis, the sepsis, the pneumonia, okay, the COVID, whatever caused the respiratory failure, you put them on oxygen, right? That's the only way you can keep them alive. So keep the patient alive, give them oxygen, and then continue treating the triggering the underlying cause. Does that make sense? Okay. So let's look at the causes. Okay. So here are a few because there's two types of I forgot. There are two types of respiratory failure. There's oxygenation failure, and there's also ventilatory failure. There's oxygenation failure, or also called gas exchange or hypoxemic respiratory failure. So those are the terms used by different authors. Oxygenation failure, hypoxemic failure, or gas exchange respiratory failure. Okay, so three different terms. And then there's also ventilatory or hypercapnic failure. Hypercapnic or ventilatory is, well, first of all, oxygenation failure is a failure of gas exchange, meaning the underlying cause prevented normal gas exchange, which is present in sepsis, right? In pneumonia, in COPD. Okay, so those are gas exchange problems. Let's say patient aspirated, okay, gastric contents. So those are gas exchange problems. So they led to hypoxemic respiratory failure. And then there's also hypercapnic or ventilatory failure, because what happens to your CO2 levels when your respiratory rate and depth drops? Meaning, let's say Jamie's respiratory rate is 8 and then she's breathing very shallow. What happens to her CO2 levels? It will increase. That's why we call it hypercapnic or ventilatory respiratory failure. Does that make sense? Okay. So meaning, let's say I overdosed on fentanyl. So what's my respiratory rate? Okay, so I'm breathing probably 6 or 8 per minute. So that's incompatible with life, right? So I'm breathing very shallow, so my CO2 levels rise. Okay, so I'm in ventilatory failure. Let's say I'm 650 pounds and I'm 5 feet tall. What do I look like? Can I go into respiratory failure?
Yes.
Yes, my belly is like this. Okay, so my diaphragm cannot push down. So I go into, my respiratory rate and depth drops and I go into respiratory failure. Does that make sense? Well, let's say I'm normal like this. No, I'm not that fat. But then my partner is 700 pounds on top of me. So can I go into respiratory failure? Yes. Okay. So there's different there. There's pulmonary and there's also non-pulmonary causes. All you need to look at is how does it affect the patient's pulmonary system? Does it affect the oxygenation or does it affect the ventilation? So those are two different matters, right? Yeah. So here are a few examples. So if it's hypercapnic, you have drug overdose, head trauma. Why head trauma? Because what happens again when you have head trauma? There's brain herniation, right? Because of increased SCP. So the brain stem pushed out, respiratory rate drops, right? Consciousness drops. Do you see the point?
Yes.
Okay. So you don't have to memorize. All you need to see is what happens to the patient's respiratory function with this condition. Let's say infection. Is this which is sepsis? Is this hypercapnic or is this hypoxemic infection
Infection.
like pneumonia, COVID, sepsis,
That's oxygenation failure.
oxygenation,
Hypoxia.
hypoxemic, hemorrhage,
Hypercapnic.
where would you put hemorrhage? You're bleeding,
When your
blood pressure is low,
blood pressure is low, tachycardia.
hypoxemic. Okay. Guillain-Barré syndrome.
Yes,
ascending paralysis. Where would you put this,
they can't breathe.
Jamie? Hypercapnic. Okay, because there's respiratory arrest here, right? Respiratory depression, because paralysis of the diaphragm. ALS,
That also affect
hypoxemic or hypercapnic? Hypercapnic. Respiratory paralysis again, right? Yeah. So therefore, so it's easy to answer, right? So look at select all that apply, you choose. Is this hypoxemic or is this hypercapnic? Kyphoscoliosis. So kypho and scoliotic. Is this hypercapnic or is this hypoxemic? Hypercapnic. Very good. All right, there you go. You got it. Cystic fibrosis. This is hypoxemic. Remember, the patient's lungs are full of mucus. Okay, that's gas exchange problem. All right. Okay, let's go to manifestations. Again, just like PE, there are no exclusive manifestations for respiratory failure. So just like any patient who has low oxygen, low PaO2, high PaCO2, low pH, low oxygen saturation, what do these patients look like? Tachypnic, right? So are they okay mental status? No, confusion, right? Restless, right? So non-specific. Okay, so the patient's in respiratory distress, basically. Okay, plus mental status changes. So here you go. Lethargy, or mental status changes, confusion, tachycardia, tachypnea, there's cyanosis, diaphoresis. Okay. Good thing again, what's the treatment for respiratory failure?
What's the what?
What's the treatment? How do we treat respiratory failure? Oxygen. Okay, so you give oxygen. You start with nasal cannula. Didn't work. Go to a mask. Didn't work. Go to a non-rebreather. Didn't work. Call a doctor. We go for BiPAP. Didn't work. Intubate. All right.
So that's the last resort.
Yeah. So BiPAP, last non-invasive, and then we still don't get any improvement. Then we'll have to intubate and put them on a ventilator. But they do respond eventually. So again, the goal here is to ventilate the patient, maximize oxygenation while treating whatever was the underlying cause of the respiratory failure. Are we on the same page? Right. The rest are, of course, are these patients able to walk around, go to the bathroom with respiratory distress like this? No, these are bedbound. So the rest, of course, are related to preventing complications from immobility. So they prevent DVTs, pressure injuries, because these patients can do squat. All they're concentrating on is breathing. Yes.
Next week's quiz on everything you have today.
Yes. Good question. All right. Intubation we'll discuss for next week. Okay. Intubation, by the way, and airway management, I don't think it's in the blueprint. Let me see. For gas exchange.
Did you do ARDS?
No, we still have time. We're not done yet. No, we stop at ARDS. Yeah, so no, what did I say? No airway management. So we'll do that for exam, our final exam. Right, so let's finish up. So last topic, also very short, is ARDS. So what is ARDS? This is a progressive form of respiratory failure. It's still respiratory failure. So therefore, since it's respiratory failure, what does ABG look like?
That's the alcohol.
PaO2 less than 60, PaCO2 50, pH less than 7, oxygen saturation less than, okay. This is respiratory failure, but this is a progressive form of respiratory failure. Main cause is acute lung injury. Now, same thing as acute respiratory failure. Acute lung injury has many causes. It can be direct lung injury, or it can also be indirect lung injury. Let's start with direct lung injury. So name things that will injure your lungs directly. Can we do that with aspiration?
Yes.
Let's say you fell down a manhole during a flooding. You were walking down, I don't know, downtown Manhattan, and then there's a flood, and you didn't know there was an open manhole. You fell into the manhole, and then you came out around, I don't know, the Battery Park. Okay, so you fell into the sewer. You got flushed out. You came out of Battery Park. Okay, came out of like that, and then you were unconscious. You were found, and then you were rushed to the hospital. So your lungs are filled with mud and whatever else is in the sewer, right? It's rat, rat doo-doo in your lung. Okay, so all of that. So is that acute lung injury? Is it direct or indirect? Okay, so and then name other else. You aspirate something else, right? So you got COVID, you got pneumonia. Okay, so any diseases, okay, affecting the lung or any poisons, toxins. Okay, so let's say you have carbon monoxide poisoning. Remember from burns? Okay, you have inhalation injury. Is that direct lung or indirect? Those are all direct lung injury. Okay, so endless. So there are pulmonary and non-pulmonary causes also. Okay, so for non-pulmonary causes, they're usually indirect lung injury, meaning sepsis. Okay, sepsis can cause, remember, this can cause capillary leak syndrome.
Yeah.
Okay, right. So those are indirect lung injury. So the characteristics here, how do we arrive at a diagnosis of ARDS besides your ABG looking like crap, is X-ray. Your X-ray, what do normal lungs look on X-ray? What do you see on a chest X-ray? You see the heart, right? Then you see the ribs, right? Do you see the lung on X-ray? No, it's black, okay? So lungs are invisible on X-ray because they are filled with air. So they appear black. You'll just see the silhouette on the sides, okay? but you don't see the lung because it's air-filled. Here in ARDS, the lungs look white. White. Everything is white. You see the heart, and then on the lungs, you're supposed to see black. It's all white. Okay, it looks like ground glass, like broken glass. Not just broken glass, but ground glass. Have you ever ground glass? Whether it's green, brown, or clear glass, what happens to it? What does it look like if you pulverize it? It looks white. Okay, so that's how your lungs look. So there's a white out appearance on the chest X-ray. So why does it look white? Because it's wet. It's filled with water. Now, how did water get into the lungs? Now, the acute lung injury causes capillaries to be very permeable. There's increased capillary permeability, well, just like a pimple. Let's say you pop your pimple. What happens after the bleeding stops? What comes out of the wound, the hole? Fluid, right? Fluid leaks out of the hole in your face. That's capillary leak. Okay, so this one is localized inside the lung. So the capillaries around each of those 100 million alveoli become very leaky. And of course, when they leak fluid, where will the fluid go? Inside the alveoli. So now, unlike acute respiratory failure, who responded to oxygen because the lung there is dry, here, if the lungs are wet, if you give them oxygen, how's gas exchange going to happen if the lungs are wet?
It's not.
So these patients will have refractory hypoxemia. Okay, so this is a defining characteristic or characteristic feature of ARDS. You have refractory or unresponsive to oxygen hypoxemia. You give, no matter how much oxygen you give, they do not respond. They remain hypoxemic, right? So that's the characteristic of ARDS. One last thing is, when the lungs are wet, is that called pulmonary edema?
When it's white, it's white.
Yeah, when the lungs are filled with water. Do we call that pulmonary edema?
No.
What do you call it then? What do you call it? There's water in the lungs. What happened in heart failure? Was there water in the lungs? Yeah, there was water in the lungs. So what do you call it? Pulmonary edema. What do you call this? Pulmonary edema. Okay, same. If you put the patient with heart failure and ARDS side by side, their X-rays look exactly the same. You can't tell them apart. The difference here is when we measure the patient's internal blood pressure, meaning we'll put in a pulmonary artery catheter. So instead, we'll put in a catheter through the neck and then put that straight into the pulmonary artery. The pressures in the heart are either low or normal, meaning it's not a heart failure problem. Do you understand? So this will help us diagnose this as ARDS. Okay, because again, it doesn't make a difference. On X-ray, looks white. Patient with heart failure, X-ray also looks white. Difference here is non-cardiac pulmonary edema. How do we know it's non-cardiac? Because the right atrial pressure or the pulmonary artery pressures are what? Low or normal, right? Unlike in heart failure. In heart failure, it will be sky high.
Oh, but is it similar to BNP?
So, okay, very good point. What will be the BNP in ARDS?
No.
Normal, because again, this is not cardiac. Okay, what caused the pulmonary edema? The capillary leak. Okay, the capillary leak is causing the pulmonary edema from acute lung injury. So again, this is the summary of this is not all inclusive. Okay, so these are just some of the risk factors. Chart 19-20. So this will lead to acute lung injury, leading to causing ARDS. So aspiration and describe, when you fell into that, who fell into that sewer? We didn't put a name. Oh, let's put Bettina. Okay, so Bettina fell into that sewer, right? Or drug ingestion and overdose. So you have a long list here. Okay, so again, very good. Select all null apply question. So I mentioned the capillary leak. So here, so we got alveoli collapse because of the inflammatory infiltrate. You lose surfactant, so the alveoli collapse and fill with water. So early on, you do a series of X-rays, it'll get worse. White today, whiter tomorrow, even whiter the next day. Right? That's how here. And again, do they respond to oxygen?
No.
No. Here, arterial hypoxemia does not respond to supplemental oxygen. And that is characteristic of ARDS. We won't distinguish mild, moderate, or severe ARDS. I mean, it's more like a progressive, okay? Meaning today it looks mild, and then tomorrow moderate, and then finally severe. So the lungs are wet. So therefore, is it easy or hard to ventilate a wet lung? Very hard, okay? Because now the only way these patients will have gas exchange is with a ventilator. We cannot, because if you think about it, if you put them on non-rebreather mask, what's that gonna do to the water? Nothing, right? Because there's no pressure. Let's say BiPAP. BiPAP also does not really push enough pressure. So BiPAP probably have 5 or 10 centimeters of peak, but you don't have an airway, right? In BiPAP, you're still breathing through your nose or your mouth. So BiPAP will not work. So the only way is to put an artificial airway inside you, either endotracheal tube or tracheostomy tube, and then put you on a ventilator. The ventilator will push all that air in, push the water out back into the capillaries, allowing gas exchange for 1 or 2 seconds. But then, once the ventilator stops to allow exhalation, the water returns back to the alveoli because the capillaries are still leaking. Do you understand?
Yes.
Meaning, let's say if this is your air sac, okay? So it's filled with water, right? There's capillaries all around it. So the moment the ventilator gives a breath, all that water will be pushed out and returned to the capillaries for 1 maybe or 2 seconds. However, once the ventilator stops giving a breath and then the patient exhales, as the patient exhales, CO2 comes out, water
Comes down, right?
goes right back inside.
Oh.
Okay. So how long will this last? We have no idea. The patient's capillary leak is self-limiting, meaning it will eventually resolve. When? We do not know. So remember COVID? This was what's happening in COVID patients. So the patients did not die from COVID. They died from ARDS, from DIC. Okay, so this is what killed those patients, right? So this is the immediate cause of death. Of course, on your death certificate, we'll see you put there COVID pneumonia, but the technical cause of death is this. Okay, just ARDS. Okay, patient, of course, no, the lungs are again very stiff. Okay, so you can call this reaction, this capillary leak response, is like a self-destructive reaction to a severe injury. Okay, so acute lung injury has severe consequences on the pulmonary system. Because how does the body respond to acute lung injury? Capillary leak. Okay, it's like overwhelmed. It doesn't know what to do, and then just starts leaking fluid. And I was already mentioned, this is a short topic because what's the only treatment for ARDS? Okay, oxygenation support, whether you give that non-invasive or through invasive means, meaning we intubate and then put them on a ventilator, and then we treat the underlying cause, just like acute respiratory failure. Right? Well, as already mentioned, we'll finish up with airway management and mechanical ventilation next week. For drug therapy, there's really not much here. Let's talk about fluids, because remember what happens to the blood pressure here? Because the lungs are wet, so what happens to pulmonary blood pressure? For the heart, when the heart pumps blood to the lungs, is it easy or hard? Very hard. So therefore, what happens to pulmonary pressure? No, pulmonary blood pressure. Let me repeat. Is the heart having a easy or hard time pumping blood to the pulmonary arteries? Very hard. So what happens to pulmonary blood pressure? Increase. So the patient has pulmonary hypertension. So now what happens to the heart? Cardiac workload.
Pumps fast.
It increases. So what will the patient eventually end up in? Heart failure, correct? Okay, so this will result in heart failure. Now, when you give fluids because the blood pressure is low, what will happen if you give a lot of fluids? Where will this fluid go? Remember, there's capillary leak.
Go back into the lungs.
It will make the pulmonary edema worse. All that water will just end up in the alveoli. But what will also happen if you don't give enough fluids? What happens to blood pressure? Blood pressure also drops. So you can see the dilemma we're in here.
Yes.
Because the patient is damned if you give too much fluid. You're also damned if you don't give enough fluids. Okay? So the mortality of ARDS is about 42 to 50%. It was the same mortality before the World War II. This is now 2024. Can you compare World War II healthcare to 2024 healthcare? Which one's more advanced? Now, but the mortality did not change for ARDS. We still can't beat this. Okay, it's still 42 to 50%. So what can you say about ARDS?
Very bad.
High mortality. There's nothing, we're helpless against this thing. Okay, because of that self-destructive response again. If we can only stop that capillary leak somehow, then everything will be okay. But we can't. We don't know how. Right? We've tried steroids, no benefit. All right, so we'll continue with the airway management and mechanical ventilation next week.